Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey, thanks for listening. This is episode 3. I'm Skinny Medic, and this is my co-host, Sean. Sean, I think we need to do an episode about diabetes very soon, dude.
Oh, wait, why? Well, dude, come on. Another one? Another fat joke? All right. Well,
I just got to keep throwing them in there, man.
that's fair. It's Skinny Medic and his fat cohort. Hey, Dietrich, today we're going to talk about two important things. And I guess before we even go into that, we'll talk about what we talked about last week. We did phases of care, like an introduction to phases of care. And we also did an introduction to March. So massive hemorrhage, massive bleed, airway, respiration, circulation, and head injury and heat loss. And this week, we're going to kind of dig down just a little bit more. First off, we're going to talk about the first phase of care, which is either direct threat or care under fire, depending on which one you go by. And then we're going to talk about massive bleeding, massive hemorrhaging. Let's go ahead and just kind of start out by direct threat. When you talk about direct threat and care under fire, what are some of the things that you go over?
You know, there's some big scenarios we can think about when a direct threat, or, like I typically word it to civilians I'm talking to, is that you are doing medicine in some bad places. Whether this is, like you were talking about last week, a car wreck, it's middle of the night, it's dark, there's no street lights around. Like there's a real danger that you may get hit by another car, or there's fire, things like that. Or you're involved in active shooter and there's bad guys still shooting. And then, I always think about, I always make the joke, like nothing good ever happens on a Sunday afternoon at 2 o'clock, 75 degrees outside. It's 2 a.m. in the fog, in a kudzu patch, and you got a guy bleeding to death. Like that's where crap hits the fan. So, that's that mindset of, we're not doing a complete detailed exam here. Like we're in a bad situation and this is what we're limited to.
Yeah, for sure. And when I talk about direct threat, I break it down to like two things. For me, the two principles under direct threat are gain the advantage over the threat and consider hemorrhage control. So I guess first let's talk about gaining the advantage. And if some of this is repeated, I apologize. We're trying to break it up so we can dig deep into this and only have a certain amount of time every week. But active shooter, what are some of the direct threats, the secondary threats, and so on and so forth?
First of all, like I always talk about, you have to make a canoe out of the bad guy's head. You got to shoot the guy in the face. None of this cool, sexy trauma stuff can happen while the bad guy is still killing people. Mm-hmm. And, when I train law enforcement officers, we talk to them about it. We used to sit, wait, and talk on SWAT. And, we would post up and wait on them. And now it's like, no, when the first arriving officer gets on scene, they hit the front door and they go towards the fight. And it's the same thing for civilians. If you're at the mall, you're at the movie theater, you're at your office, and you hear gunfire, then you need to run towards the threat. And hopefully you have some training to back that scenario up, that you can go towards a threat, because you may stop and try to do bleeding control on one person, but the bad guy is still shooting people. So as you're trying to control bleeding on one person, he is putting 3, 4, 5 more people on the ground. So you got to step over those people. You got to step over grandma. You got to step over the little kids. But you have to make that big step and go shoot the bad guy in the face.
Yeah, you have to gain the advantage, because bottom line, especially as a civilian, you don't have any department behind you. You don't have, backup on the way. That's it. You're there. And if you go down because you're paying attention to putting a tourniquet on somebody instead of paying attention to gaining the advantage over that threat, well, who's going to be there to help you? Like, bottom line is a whole lot of people in the universe don't care about this kind of stuff. And the people that do, that's fantastic. But what if you're that person and you go down because you didn't pay attention to not just the primary threat, but the other ones? It's a really big deal. And we really have to be cautious as civilians when we go into these things, just because it's so dangerous for us, and we can't expect backup or, the A team to show up and take care of things. But not only is it the direct threat, there's like all kinds of other threats as well, right? Like for active killer environment, there's the active killer. They could have a partner, other concealed carriers, law
Yeah, I mean, I
enforcement.
think about, you got other people that are maybe carrying a gun, and for me, like, I'm always like, you know what? They're gonna see that skinny white kid running down the hallway, and like that's the threat, and they're gonna shoot me, and I'm like, dadgummit, you know, statistically, there's probably only one shooter, and if there is, another shooter, they're within eyesight of each other. But they've looked at other threats now. So think about smoke, fire being used, hazardous materials is something that is starting to play around with, and always bombs is a real threat. That you have an active shooter, but he's also planting some bombs to kind of, because let's face it, you're involved in the situation, but then you have first responders who are a great target to come and get. So, those first arriving ambulances, those first arriving firefighters, if they can plant some secondary devices, that's perfect. Just to blow up a bunch of firefighters, that'll make the news. So that's a real threat that we have to think about as civilians. You just don't get tunnel vision on just one thing. Think about your surroundings.
Yeah, and we give examples like this just because we're trying to open up your mind a little bit to think about all the different possibilities. Let's say a car accident. What are our direct threats, and what are some other threats that may evolve and become emergent?
We think about traffic always. Like, that was my fear when I worked EMS full time. We'd run interstate calls, and I was like, man, I just do not want to get hit by a car. That's not the way I want to go out of this world. I think about gasoline fire happening. You're crawling inside of a car that's unsteady, like you were talking about. Last week, the car on its side. That car is super unsteady. You start trying to crawl in that car to provide patient care, and all of a sudden it rolls over. It finishes the complete roll onto the roof, and now you're entrapped, and now you've got a problem. So there's fire. There's always chemicals. Even it's not as bad as it used to be. Like airbags. There's airbags everywhere inside of a car, in the posts, in the pedals, and so you start messing around with stuff, and all of a sudden the airbag hits you in the face, and that's gonna leave a mark if it doesn't take your head off.
Right. Definitely agree with that. And I think we talked about a bunch of this last week, so I guess we don't need to drill down too much more into those kind of scenarios. Just remember, to everyone who's listening, these kind of things we have to take care. We have to gain the advantage over that threat, whatever it means. Whether that does mean shooting the bad guy in the face, whether that does mean watching out for nauseous fumes or things that might, make us pass out, or oncoming traffic. Or just, at a shooting range, someone accidentally shoots themselves in the hand. The threats are them, clearly, them kind of waving the gun around, other people turning to see what everyone's yelling about, and their gun turning with them. There's just so many additional threats that we have to pay attention to. And that's why, under direct threat or care under fire, we can only pay attention to gaining the advantage over the threat and then considering hemorrhage control. Now, when we say consider hemorrhage control, what are we kind of talking about there?
I think about, like my example, there was a video popped on Instagram, Facebook, of two cops that are involved in a shootout on a sidewalk, and the officer gets struck in the leg, and the other officer pulls out his tourniquet and says, "Here, let's put this on." But the bad guys, they're still actively engaging in the threat. So, there was a lot of talk about this. This guy, I didn't see a lot of blood, but they're still actively involved in shooting the bad guy. So, let's put the tourniquet on, and then 5 minutes later, when the threat has been eliminated, sit back and evaluate this tourniquet. Do we really need it? Can we take it off now? Now you're entering to a different phase of care. Take a look at it. It's easier. Your adrenaline's pumping. You may not even realize you've gotten shot because your adrenaline's pumping so hard that just go ahead and put the tourniquet on. It's not going to hurt anything for being on for 5 or 10 minutes. Once the threat is eliminated, we can evaluate it. My example of being 2:00 in the morning, you're in a kudzu patch, it's pouring down rain, you feel a lot of blood with your hands, put the tourniquet on, and then once you pull the patient up to where you've got more light, maybe you get a flashlight, a headlamp, or something like that, you can see better. You're like, oh, this didn't really need a tourniquet. Let's downgrade it. There's nothing to say that once you put a tourniquet on, for that quick a time, that you can change it out and correct it.
Yeah. Now, we literally just talked about, as civilians, when we put ourselves into these situations, or even if we're just put into the situation and we have no control over it, just leaving is kind of always an option, right? We're under no obligation to provide aid of any sort, whether it's helping gain advantage over the threat or doing the right thing medically. And sometimes just putting ourselves in or being in a situation like that, we can really put ourselves in a situation where there's a no-win. So is leaving just an option?
Yeah, I mean, for a civilian, I would look at your, state laws just to confirm, but, no one's ever going to tell you that you have to draw out your Glock 19 and run towards the fight. No one's ever going to tell you that you have to go down into that kudzu patch and put your life on the line. But I feel like you have to do whatever you can lay your head down at night with. If you can lay your head down that next night and go, you know what, I'm good, and go to sleep, cool. But if you're sitting there like, man, I will not be able to sleep tonight if I don't go turn around and go see if that car wreck's okay. I'm not going to be able to sleep tonight unless I know that those guys in the next room are okay. Then that's a personal decision that you have to make to whatever you can sleep at night with, whatever decision you make, either way.
Yeah, and I think that's very well said. And just don't forget, like, I'm not recommending people run into the fire. I'm not recommending people just run away from the fire. Like you said, what can you sleep with? And sometimes gaining the advantage over the threat is just leaving the area that the threat exists in. So just something to think about. We all have to make our own choices in those situations. And I assume that most of us are going to make, probably the same choice, which is to go into it because we care about things. And that's why we listen to podcasts. That's why we train medically. It's why we train with firearms, all those different things. Communication. This is kind of a big one, right? One of the first things that we do when we get into traumatic situations or just situations that get the adrenaline pumping and the heart beating is we get tunnel vision and just auditory and visual exclusion and really just focus on like one thing. And one of those things is we stop communicating with, the people who may be injured, the people that are around us that might be able to help, and the authorities as well. Would you agree with that?
I agree. And, when we get stressed, we tend not to be able to multitask as easy. And so your hands are working and then your mind's going 90 miles an hour. So your mouth stops moving, and that's for me, like I've had partners go, man, you sure do talk a lot during a call. And I do talk a lot because I'm like, all right, I've got airway under control. What's the next thing I need to do? Respiratory. Like if I'm talking out loud, then my partner goes, oh yeah, this is the next step. Or, hey, let's go back and look at this. If I'm talking out loud, then that's what, what I'm thinking. And for civilians, I think goes the same thing. If you've got a group of men and women that are working on one patient, talk out loud, like talk to the patient, find out what they're, I always laugh. I'm like, what is their name? Like, what is their birthday? Like, what's their favorite way to cook asparagus? Like, I will just start randomly talking to them. And so they're communicating with me. Maybe their mind's getting off of what's going on, the bad situation, things like that. But especially if I have a group of people who are working with me, I'm like, all right, guys, we have got a tourniquet on the right arm, we've got a tourniquet on the left arm, we've still got some bleeding, and let's figure out where the bleeding's at. If I'm running through the game plan in my head, then it helps others help me provide care.
Yeah, and I mean, asking people around, hey, can you call 911? This is what I want you to tell them. Just things like that, just communicating with people who can help in any way, the casualty, and it helps keep you really engaged as well. I've always found not injuring yourself or causing further injury to the casualty is another thing to consider. If you can drag somebody by their hair, are you going to cause further injury to them, or should you try to figure out a better way to do it?
Exactly. And I think people are standing around a lot of the times in these bad, whether it be a car wreck or whatever, they're standing around because they don't know what to do. If you give them direction, like simple directions, like, don't tell them I need you to call 911, then go get me a coat, go do this. Like, just give them simple directions. I need you to call 911. And then look at someone else going, hey, I need you to go get me a blanket. And just kind of give them clear, direct communication, directions, feedback. And then, a lot of times if they're super stressed out, you can tell like they're just bug-eyed. I'm like, what did I say? I need you to repeat it back to me. Oh, you said go call 911. Yes, go call 911. Oh, you did say go get you a blanket, correct? Yes, go get me a blanket. To get them to repeat it back to you so that you heard that clear, closed loop communication going on.
Yeah. Now, in the notes here, we have also self-aid, which I think is actually huge because so often we go to medical classes, we train, we learn the skills that we need to do, and then we forget that other people can also do things as well. So a lot of times we'll run into a situation that puts us at great personal risk and just instead of just telling someone, hey, do this, do that, even throwing them a tourniquet, right? Like self-aid is a huge part of our toolbox, if you will, when we talk about just being a civilian medical person.
Definitely. In one of my classes, I always bring up the video from years ago that it was this guy, he's in like the fetal position. He's behind a shooting stand. His buddies run up behind him. His buddy, kind of gets on top of him and he's like, "Oh, my tourniquet's right here on my belt." He pulls off the victim's tourniquet off his own belt, applies it. And I'm like, if that guy can point to you where his tourniquet is at on his belt, he can probably apply it himself. There's no need for you to kind of do the cool, shooting stances, all this stuff. If you could just stay behind cover or concealment, then you can talk to them. And this is super difficult. If you've never tried it, have some fun with it. Like grab your kids and like put your kids in a hallway and you're in a room. You're like, all right, pull the cat tourniquet out and make a loop. Pull it through your arm. Like it's difficult to try. And even when someone's not stressed out, to talk them through that. We do it over the radio, and that way I can't see what the victim's doing. I'm just like, all right, John, I need you to pull the tourniquet out of your holster, loop it through. Like and you can't really see the patient sometimes, and you're just doing it strictly over radio communication. It's difficult.
Yeah, it 100% is. So there's always two training scenarios that I do in classes because they really help reinforce this. The first one is I put one person in a room and another person outside the room, and then I close the door. And then I say, that door isn't a door, it's a telephone. And your brother's in there, and he has this injury that I've already coached him on. And now you have to you have to talk him through it. You have to ask the right questions. You have to make the right assessments. And then you have to help him treat himself. And depending on what kind of injury it is, it's so incredibly difficult. But it always kind of makes them think, oh yeah, you know what? I can tell somebody how to do these things. I can do assessments based on the things that we have that they tell me. And then the second one that I always do is the Harambe protocol, which is gorilla drag somebody into an enclosure. You cannot go in there. That person has like a femoral bleed or something like that. Anything that you try to do, the gorilla is going to take, or if you try to go in there, the gorilla is going to kill you. What do you do? And that just helps them, throw a tourniquet, turn away from the gorilla, don't make eye contact. And it really helps them talk somebody specifically. And the person that's in the gorilla enclosure, they have instructions that you do exactly what they say. If they say something that's ridiculous, you do it, and then they have to overcome it and figure it out. And, gaining the advantage over that threat is not going in there, but considering that hemorrhage control as well and doing it and explaining it. And I think those two, they really help reinforce the fact that you don't have to be hands-on. You can tell someone to do something and you can explain to them and teach them how to do it as you go.
Absolutely. I mean, that's a great exercises to do. You can do that with your kids, your wife, your buddies at the office. I mean, you can definitely run through those drills. And like you were saying, sometimes, if you put yourself in too much danger, you push the envelope too much, now you become a casualty, and now you have two patients to deal with. So sometimes, like you said, it's just easier to let them provide self-aid and you stay where it's safe so you don't create another casualty.
Yep, 100%. Gain the advantage over the threat and consider hemorrhage control. That's pretty much hemorrhage control that is life-threatening and controllable by tourniquet, right? Because we don't wound pack under care under fire or direct threat, right?
Right. I mean, you're going to be putting way too much effort, and you're going to come off of your security element or whatever to start wound packing. It takes way too much time. Tourniquets, absolutely. If I could get a bystander to kind of help me there, but definitely if you're still under that bad situation, tourniquet only.
Yeah, 100%. Just too much focus, too much time, and we're trying to gain the advantage over the threat before we do any further interventions of any kind. And that's pretty much under direct threat and care under fire. There is one other thing: is we always have to consider C-spine stabilization. And if you could just explain real quick, what is C-spine? Why is it a concern?
So this is when we were concerned about someone having a spinal cord injury, whether it be from a fall or some kind of other traumatic event, and we will either hold their head still or direct the casualty to hold their head still. This is one of the things we've done a lot of work pre-hospital with this. So, used to, we would put you in like what was called a KED, which was this like big, huge thing wrapped around you. We'd move you out of the car, and like that doesn't work. And for a long time, most of my EMS career, we were putting patients on backboards, which were hard plastic boards, and they're perfectly flat. So you take someone who's back, who's not perfectly flat, it's got this big curve shape, and you're strapping them down. It was a great torture device. But we're seeing a lot of information come out saying now that, you know what, if you're going to have a spinal cord injury, it's going to happen on the moment of impact. So we're not overly concerned about it as much as we were, say 5-10 years ago, but it's still a consideration. So if someone has some kind of traumatic event, if they're awake and talking, then I will tell them to hold their head still. There's no need for me to reach down and keep their head holding still for 10-15 minutes while I wait on EMS. If I can tell you, focus on the ceiling, focus on the steering wheel, focus on this, just keep your head still, try not to move it, then that's what I'll do. But unless there's something life-threatening, like a fire, or the car's on fire, or there's still an active shooter and you're still in bodily harm, then I'm going to drag you. I'm going to make the quickest, easiest way to do it. But I'm going to move you. If you're in a car wreck and you're soaked in gasoline and gas is still pouring on you, that can cause some second-degree burns. And so I'm going to get you out of that situation. So I don't care that your neck and back hurt. We're going to move you.
Right.
So
it's that trade-off, right? Like burn to death or possibly be paralyzed. Take your pick. It's a choose your own adventure. Now, I always talk about mechanism of injury, and that's just basically the method in which they were injured, and we can make assessments based off of what that mechanism of injury is. Like Christopher Reeves going over the front of a horse, clearly mechanism of injury that could lead to C-spine issues and paralyzation. Blunt trauma, like falls, hitting your neck, all kinds of different things like that can all lead to that. What about penetrating trauma to the neck or spinal area?
So like for penetrating trauma, we're not as concerned about C-spine as we are the blunt trauma. I use the example of someone who gets shot in the chest. If I shoot you in the chest, you're probably not going to want to lay back onto a backboard. You're probably going to be having some trouble breathing, so you're probably going to want to sit forward and lean forward. And I think that's probably the best way to sit someone. Then I have to, if you go to vomit or whatever else, there's blood coming out of your mouth. If you're on your back, then there's a risk of you choking on that, things like that. So if I can keep you leaning forward in a position of comfort, then that's where I'm going to leave you. So we're not as concerned about penetrating trauma as we are blunt trauma. Like you said, Christopher Reeves, that's blunt trauma, causes a spinal cord injury, which separates the spinal cord. That's your nervous system. Now you can't move your arms or legs from where maybe it's waist down, maybe it's nipple line down, wherever. But penetrating trauma, we're not as concerned about it. There again, if you're going to get an injury, it's probably going to happen in the moment of impact.
Yeah. And so again, the reason we talk about this under that direct threat care under fire scenario is because sometimes gaining the advantage over the threat is leaving the situation. And if the casualty can leave the situation with you, that's great. We just have to kind of take a split second and think about mechanism of injury and kind of decide, A, should they move? B, is it worth it? If we do, and just more things. We talk about so many gray areas in on this podcast, and this is one of them. We have to make our best assessment. And don't forget, we talked about negligence when we talked about Good Samaritan laws, and it's standard of care not met, duty of care, and causation. So we're trying to avoid those things. That's why we think about all this other stuff.
Exactly. And one of the things we talked about, in like a military or police officer class is getting off the X. If you have a bad guy who's got a point on someone and he has shot that person and they're on the ground, that's the X. So if you go over there and you start providing care and a gunman has range on that guy, he now has range on you. So maybe the best thing to do is to move the patient out of the hallway before you start beginning care. Would simply have a victim down in the hallway, maybe reach and grab them by their jacket or whatever, their ankles, and we pull them into a classroom, and that's where we begin care. Doesn't make sense to begin care when the bad guy is still shooting and we're on the X. So if we can get them off the X, then we provide a little better patient care and we don't get shot.
Yeah, I love that. I think that's pretty much all I have for direct threat. Gain the advantage, consider hemorrhage control, and everything else that was kind of in there as well. So I think it's time to move on to massive bleeds, which is that massive bleed, that hemorrhage control that we're even considering. So first off, what's a massive bleed? I
say it's, oh my gosh, that's a lot of blood. I say it in my videos, and I didn't even realize I was saying my videos until somebody started commenting on it. But I'm gonna get a T-shirt made. It says, "Oh my gosh, that's a lot of blood." Actually, I have one, and I wear it. I've worn it a couple times in Mexican restaurants, and that's always kind of fun. They get some funny looks, but that's what it is. If you walk up and in your mind you're like, "Oh my God, that's a lot of blood," it's massive bleeding.
Yep, absolutely. I think we mentioned in the last episode how much blood is in the human body: 5 liters, 5,000 cc's. And,
Correct.
and I mean, just think about it. Like if you lose half the blood in your body, you're probably stage 2 hemorrhagic shock and probably going to die. So think about what 1 liter is. Pour a 1 liter bottle of water on the floor, and that's what 1/5 of the blood volume that you have in your body is. And it's going to look like a lot depending on the material. If pour a 1 liter bottle of water down your pants and tell me how much ends up on the floor. Not going to be a ton, right? It's going to soak into your pants, just like in the real world, and what blood does with our clothes and things like that.
Exactly. I talk about my classes. We do a lot of classes in the South. So instead of saying we're in the Bible Belt, I always say that we're in the bacon belt. So like everybody has diabetes, cholesterol, heart problems, and all of that is going to affect your ability to control major bleeding on your own. So, if you've got these medical problems, then you're not going to clot as well. So you've got this big nasty cut, whether it be from a chainsaw, an axe, or whatever happened, a piece of glass cut you. And like you said, now your blue jeans are soaked in blood. They're absorbing all this blood. And you're like, I don't know if I should put a tourniquet on or not. If you're like, oh my gosh, there's a lot of blood on his blue jeans, you should probably put a tourniquet on it.
Yep, agreed. Now let's talk real quick. There's basically 2 concepts. There's the platinum 10 minutes and the golden hour. And this is from point of injury. The golden hour is from point of injury to the surgeon's table. Like if you can generally get them from there to there in that first 60 minutes, they have a decent prognosis of survival, depending on what the injury is. But in this podcast and a lot of the stuff that we do, that platinum 10, that first 10 minutes from point of injury until the next level of care gets there, because response times generally around 10 minutes in most urban places in the country. You're going to be over that, and in rural environments you'll be over that. But generally, from point of injury to that next level of care getting there, that platinum 10 is hugely important. And it's important because we talked about it last podcast, episode 2. You will circulate your entire volume of blood in 1 minute. So that 5 liters basically goes through and perfuses all your organs and tissue and everything in 1 minute. If a femoral artery is cut or dissected, how much blood can you lose out of that?
So typically in a femoral artery, you're going to lose about your entire blood volume about 3 minutes. So, your femoral artery, if you stand in the shower naked and look down, it's your love creases running right through there. That's where your femoral artery is, and it's the size of your thumb running on either side of your groin there. So that's a huge hose pipe that is pumping out a lot of blood very quickly. Like you were saying, you lose half your blood volume. Now you're in stage 2 shock. You're getting close. You probably can't make decisions on your own. Like you can't physically tell your hand to stop bleeding. So it happens super fast. And that's why we talk about, keeping a tourniquet on you, keeping your IFAC close by. It's got to be close by.
Yeah. And if you do get into that stage 2 hemorrhagic shock, that blood loss shock, your chances of survival are 14%, which is just, it's terrifying and terrible. Now, in addition to carrying the oxygen, our blood contains clotting factors. It's not like blood just clots. There's actually, there's clotting factors inside there. The more blood you lose, the less clotting factors you have. If those are outside of our body, we can't create the clots. That's a bad thing. And that's why even under that direct threat care under fire, we have to stop the bleed, because it's so important. And it just starts this cascade that if we don't stop that, if we go into that shock, that it's really hard to come out of, right?
Right. Your body's going to start pulling all the blood out of the arms and the legs. It's going to start the vasoconstriction because it wants to keep the heart and the brain alive. Like it knows, like if I pull all the blood to the core, I can stay alive longer. And then the next stage is like, you know what? I really don't need these kidneys. I can live a few days without the kidneys. And it starts shutting those down. And then it starts shutting other organs down. And then it just starts cascading until the body can't survive anymore. And it doesn't matter if you're on a surgeon's table, you can't survive anymore. So you've got to keep those red blood cells have to stay on the inside. Like you were saying, the platelets, they're basically little balls that have hooks on them. So when they start hooking together, it starts building a wall. But if the hole is so big that it can't start building that wall up, then it just free flows out. And like you said, clotting factors, maybe someone they're on blood thinners, they're on AFib, they have a history of AFib, they are on blood thinners because they don't want clots, in their heart, or they've had a stroke like that. Like all this just leads into that, and they can have some major problems very quickly.
Yeah, 100%. So again, that first 10 minutes, the first few seconds, that first minute is so incredibly important. So under direct threat and care under fire, we gain the advantage over the threat and consider hemorrhage control as can be applied by tourniquets because they're fast and quick and super easy to stop that on appendages. Are tourniquets safe? I mean, I always heard in Boy Scouts that it was the most awful thing you could possibly do, that you're going to lose whatever you put it on.
Were you really in the Boy Scouts? Or were you like Girl Scouts? Like, come on.
Well, I love cookies, so you know.
Yeah, exactly. Yeah, there's a lot of misconceptions about tourniquets out there. A lot of military guys were learning the whole windlass with a cravat and a stick, and they're like, if you put this on, you can count your buddy's going to lose his arm or his leg, and that's what stuck with them. But now with the war in Afghanistan and Iraq and all that, trauma has come a long way. Trauma surgery itself has come a long way since then. So, if you can have a tourniquet on and off for less than 2 hours, meaning you put a tourniquet on and they're at the trauma surgeon's table in 2 hours, there's pretty much no chance they're going to have problems. They're going to be just fine. 4 to 6 hours is kind of pushing it. You may have some nerve damage in that arm and stuff like that. But the further you push it off, the more likely you're going to have nerve damage. There's other issues, but don't be afraid of that. I use example in my classes. I would rather go to my little girl's wedding with only one arm or one leg than not be there to marry off my little girl. So I want to be at her wedding. If you need to put the tourniquet on and it has to be on for a while and something happens and I'm losing it, so be it. I will go through rehab. I'll be fine.
And let's I mean, this isn't just us saying this. This isn't just like one report. There is a ton of empirical data. In fact, the Krog Combat Journal of 2008, well, it was a combat support hospital in Baghdad. There were 232 patients and they had tourniquets on 309 limbs. CAT was found, the combat application tourniquet was found to be the best field tourniquet. No amputations were caused by tourniquet use, and only 3% of the people with tourniquets on had transient nerve palsies. And
Correct.
that's huge. Like that is empirical data right there. That is a ton of data collected over a length of time that says tourniquets are the right way to do it. And we're seeing, I think in this country, we're seeing a switch. I think we're seeing a lot of that old wives' tales kind of go away, and people are becoming way more accepting of tourniquet use.
Yeah, I mean, I had a patient that amputated his lower leg. I could see the tib fib sticking out just below the knee. I applied a tourniquet. It was a CAT tourniquet just above his knee. We had him in the hospital to the trauma bay in about probably 25, 30 minutes after the incident. He said the tourniquet hurt worse than the actual amputation, but he survived it, and they reattached it. They reattached his lower leg at my local trauma center. So, for them to do that, I was totally amazed about it. That's going to happen. So, to be scared of them, I mean, it's kind of like anything else. Like, you've got to have a respect for it, but don't be scared of it.
Yeah, I agree. In under 2 hours, you're generally going to be safe. If you're in wilderness survival mode or something like that, and you have a long walk, or you have, more than a couple hours, you have really tough decisions to make. But again, bleed out or not bleed out, and just work with the challenges of that, or, those really tough gray areas that you have to just kind of figure out what's best based on your situation.
Definitely.
Ton of tourniquets on the market. We have already talked about this a bit, just because there's so many coming out all the time and so much new information coming out all the time. But what are the types of tourniquets that you generally A, teach about, B, recommend, and C, sell out at medical gear outfitters?
So I think you could almost split all tourniquets into two categories. Ones that have a windlass and those who do not have a windlass. Windlass being a rod that you rotate to tighten it up. And there's plenty of data being provided by the trauma committee that shows that you really do need that windlass to tighten it up and to get true occlusion of blood flow. So for those who don't know, like there is a trauma committee who recommends tourniquets. There's a misconception they approve of tourniquets. They don't really approve tourniquets. They recommend tourniquets. So there's a few tourniquets on the market that they recommend, and that is the CAT tourniquet. And there's the soft T, and there's one called the EMT, and it's basically like a blood pressure cuff that's got this huge metal clamp on it, and they use it a lot in surgeries, but it's really expensive. But the two main that you're going to see that are recommended by the trauma committee are the soft T or the CAT. Both of them have their advantages, both of them have their disadvantages, but those are the ones you can see. There's plenty of other ones that have been on the market for a while. The SWAT T has been on the market for a while. It's a big rubber band, like about a 3-inch rubber band that wraps around. I like it. I think it's good for those infants, children, elderly patients that weigh 100 pounds soaking wet, that the cat or the soft T won't compress down small enough. Now I say that, but understand that the cat and soft T both compress down to 5 inches in diameter. So I know guys were not super well at measuring what 5 to 6 inches looks like. So take your tape measure, put it on 5 inches, and make a circle out of it, and you're going to see that is super small. The soft T was recently put on a 4-year-old in Texas, and it worked just fine. So they can go super small, but anything 5 inches in diameter, they really just need a pressure bandage. So that's where the SWAT T really comes into play there. I think for canines, if you're using your dog for search and rescue or things like that, it works well. The rats is another one that's popular. It has huge social media following. I don't like it. I don't think it's the best tourniquet on the market. It's super narrow. There's plenty of, go back and look at some older research about tourniquets. The narrower they are, the more likely you are to get that nerve damage occurring, things like that. There's a couple other ones coming out. Combat Medical has look at one that's, I can't remember the name of it right offhand, but it looks like it's basically a cat. It's got a windlass. And there's a few other ones that are starting to come on the market, but it's interesting. But I still think the gold standard is whether the cat or the soft T. You've got to be able to beat those if you're going to come onto the field and play.
Yeah, and I think it's important to use the stuff that actually has science behind it, and not just random reports in certain places. Like the cat and the soft T, they have a ton of science behind them. They've got tons of reports behind them, and I recommend people go out and kind of read that. But yeah, there's tons of new stuff coming on the market. But how much is your life worth? Do you want to put would you take a gun and carry it every day when you've never shot it before? No, you want to make sure that it functions right before you shoot it. And that's kind of how I feel about tourniquets. I use the ones that are recommended by the Committee for TCCC and TECC, just because there's that data and that science behind them.
And that's for me, like on my tactical vest, I run a cat on the outside. It's in its own little pouch, so I can get to it quickly. And then on the other side of my tactical vest is my IFACT, and down inside there is a soft T.
Yeah. Now let's talk about placement. First off, tourniquets can only be used on arms and legs. You can't put them around somebody's neck. You can't put them around somebody's torso. They can only be used, basically, you talked about the love creases, basically below that and below your armpit. That's where tourniquets can be used. So what if there's life-threatening bleeding that is outside of those areas and we're under direct threat or care under fire?
So, arms and legs, that's it. If you can hold pressure, get a bystander to hold pressure in those junctional areas, that's kind of where you're going to go. Once we get out of that direct threat, into another phase of care, then we can look at wound packing, things like that. But a tourniquet placement is arms or legs. And then if it's in like the shoulders, the pelvis, things like that, then you're going to wound pack. Now, we don't wound pack in the abdomen, chest areas. We're just going to put a chest seal on that and let God take care of it. But, if we can get to those junctional areas, we're going to wound pack. And the tourniquets, people talk about the high and tight, or do we put it 3 inches above the wound?
Yeah, that was my next question. Is there's a lot of information out there, and why would you do one? Why would you do the other? And who should do each one and all that?
If we're in direct threat where there's still a problem going on, don't be concerned about, I'm going to put it 3 inches above. Just go high and tight. No one's going to fault you for ever putting a tourniquet on high and tight. Going up to the armpit, pulling that tourniquet as tight as you can get it, and you wrap it, wrap it down.
Mm-hmm.
And then, but if we're talking to the EMS population, I'm like 3 inches above the wound is just fine. If you guys are in a bad situation, it's dark, it's raining, put a tourniquet high and tight. No one's ever going to fuss at you. If it is a Sunday afternoon and the sun is shining 75 degrees and your uncle hits his wrist with an axe or a knife, then that's his only injury. That's your only patient. Then there's nothing wrong with putting it on 3 inches above and securing it. Yes, you can put it down below the elbow, below the knee, the double bone. There's plenty of research to support that as well. But it's just kind of use your best judgment. We keep talking about that. Use some good judgment here. If you've got multiple patients and you're in a bad situation, don't worry about it. Just put the tourniquet up high and tight and lock it down. But if you've got one patient, the sun is shining, it's beautiful outside, then wrap the tourniquet 3 inches above, secure it, and move on. Take them to the hospital.
Yeah, just make sure it's not on the elbow. But I'm like high and tight. Like these are people who, for me, mostly in the classes, it's people that have no experience with this stuff, and I'm like, high and tight is really never wrong, but it's always right. Whereas the other one, if you're not sure about the anatomy and kind of where the right places are, then you may do the wrong thing. Whereas high and tight, it's always right.
Exactly. I'm never, me as a paramedic, I'm never going to fuss at someone for putting a tourniquet high and tight. I'm going to be super excited you put a tourniquet on. I'm like, heck, yes, that's awesome. So, high and tight, nobody's ever going to fuss at you for that.
Yep. Agreed. Let's talk real quick about improvised tourniquets. Should people just, carry a thick belt because that'll work just fine?
I think improvised tourniquets have their place. Like we've talked about survival medicine, wilderness medicine, things like that. But that should never be your plan A. Plan A should be a good quality commercial tourniquet. Plan B would be an improvised tourniquet. We saw this come into play with the Boston Marathon bombing. Dude jumps out and he starts rocking it, and he's using cravats, pressure. He's doing all of these, and ended up that everyone survived. Nobody was fine. Everybody survive those injuries. It ends up that typically, if you start trying to make an improvised tourniquet, all you're really doing is making a good quality pressure bandage. It's difficult to make an improvised tourniquet an actual tourniquet. If you're going to make one, it needs to be 1.5 inches wide at the very least. It's got to be wide, and you need a windlass. So I don't care if you're using a carabiner, some keys, or a screwdriver, whatever you're using, it's got to be something solid that you can get that windlass to get the torque on it.
Yeah. And one other thing I wanted to talk about on tourniquets here, or we have much more to talk about, but one thing I wanted to cover real quick before I forget is width of the tourniquet. It's important, right? We're talking about compressing tissue down over that artery into the bone, and width is important, right?
Yes. So, when you're compressing that muscle mass down, I've got little chicken legs, so it doesn't take much muscle mass there. But someone who's got bigger legs, it takes a lot of pressure to get that muscle to collapse around the artery, and you're pushing that artery against the bone to stop it. So it does take a considerable amount of pressure. And with the research is showing that about 1.5 inches is the optimal width. If you get anything narrower than that, you can, like some people talk about, they're going to use shoelaces or 550 cord or whatever. You actually start cutting into the muscle. You can cause more damage. You're just slicing because you're putting so much torque on it.
Mm-hmm.
But the wider, it's not as effective. So that 1.5 inch width is what is optimal.
Yeah. And I guess we can go into the myths of tourniquet use now. And I'm going to start out with one, and that's that a cat tourniquet will always occlude blood flow.
Yeah, I mean, I hope it does, but you may need two. You may need a second one. You may need to do something else. I hope it does. I hope it works, but you got to have a backup plan. Whether you're going to need to wound pack that wound, or you need to apply a second tourniquet, right beside it to get that blood flow to stop. But definitely having a plan B there is important.
Yeah, I agree. And I was actually just reading a report this morning, talking about very often, in fact, in a lot of the cat tourniquet testing, I wouldn't say very often, I don't remember the specific number, but one didn't always do the trick. And when that didn't work, they just put another one right below it. And that's another reason that I go high and tight, because then you have that room to actually go do it. So if you carry one cat tourniquet, you should probably carry two, just in case one doesn't take care of it, because it's not like you can take it off and tighten it more. You just need to apply another one, right?
Exactly.
What are some other myths?
I hear about tourniquets that the cats break. That they're going to break on you, and a lot of that is true. From like the first generation cats, they weren't using as good of quality like polymer plastic they're using now, so they had some issues in the very beginning. Like the Gen 1s, they were smaller windlasses. The polymer wasn't as good. So now, but I was on a thread the other day, and they were talking about how they haven't had a recorded breakage in a while now. So all the cats that are getting used, there hasn't been a report of a breakage in a while. So they fixed that problem several generations ago. So We kind of talked about myths before about, if you put a tourniquet on, they're going to lose an arm or a leg. And that's just not true anymore.
Yeah. What about a ton of pain means that you put it on wrong?
Yeah, no, a ton of pain means it's probably on right. Like I used my illustration earlier, that I had a victim who amputated his lower leg, and he told me that the tourniquet I used hurt worse than the accident that he was on. So, they hurt. If you get a trainer cat, or you can buy an older cat and write trainer on it, put it on your leg, your thigh, strap it down super tight, and turn the windlass, 2 times. If you can get 2 turns out of it, I'll be excited for you. And then try to stand up. And you will find that you cannot stand up, that you can't move that leg because it hurts really bad. And now you've collapsed the muscle around it, can't contract to move your leg, and it does not feel good.
Yeah, it's just basically like a big, huge peg leg from that point on.
Yes.
Which is interesting. What other myths? Is there other ones?
Trying to think. Talk about pain. We talked about the one I see a lot about is the kids. The cats won't work on kids and stuff like that, and that's just not true. We talked about that before. The 5 inches in diameter. I can't think of any good ones right now.
Yeah, I don't think there's a whole lot, but let's talk about some mistakes. Actually, there's a ton of those. We talked a little bit about only use tourniquets for severe bleeding unless you don't have time to figure it all out, and you can always go back and reassess in a couple of minutes if you need to, right?
Yeah, I think a couple of things is not using a tourniquet when it's needed. Going, ugh, I just don't think this needs a tourniquet, and all of a sudden you realize this guy's lost 800, 900, 1,000 cc's of blood, and you're like, oh, I probably should have put a tourniquet on 5 minutes ago.
Mm-hmm.
Not getting, if you're talking about a cat or a soft T, not getting that initial pull with the strap tight enough.
Yeah,
a lot of guys will leave that loose, and when they start turning the windlass, they're getting 3 or 4 rotations out of the windlass, and that just means that you did not get that initial strap tight enough. If you're putting on a cat or soft T, that initial pull is super important to get it tight. They're almost making a pressure bandage just because of that initial pull, and then you start to rotate it. The Gen 7, if you get that cat on tight, usually about a half a turn, I'm like, all right, that hurts. You're not getting that full 2-3 rotations out of it before you start feeling the pain and know that it's working.
Yep. Putting it on too close to the injury is a mistake that you can make. Usually 2 to 3 inches below, just not around the elbow or the wrist or anything. Taking off the tourniquet, that's a mistake. Surgeons take off tourniquets.
Yeah, that kind of goes back to one of the myths that, before, we got a lot of cool research and data. They were like, all right, let's put the tourniquet on, and then every so often we'll take a half a turn off of it and kind of loosen it back up to get blood flow back in.
Yes.
And that's a mistake. When you put a tourniquet on, you're getting some toxins, you're getting some free radicals. Like the pH is going crazy in that leg. There's a lot of chemistry going on below that tourniquet. And so when you start to take it back off, if it's been on for a prolonged amount of time, all that toxin starts going back into the body. And sometimes the body will absolutely freak out, and you can cause a lot of harm by doing that.
Yep, 100%. In fact, if you don't put it on tight enough, you can actually create compartment syndrome, which is a whole other bag of worms.
Correct.
And what is compartment syndrome?
So that's where you're starting to get gaps, and you've got this bicarb starts to build up, and the pH is really off in these little spots that are building up, and that will cause amputation because they start to die, and you get necrosis of the skin. So it's these gaps where you see bulging. We can see it like a lot of the tourniquets we have to wrap around. If you don't put your cats close enough, like you put one tourniquet on and you go maybe 4 inches above that for your second tourniquet, all that in between those 2 tourniquets has the ability to build up the compartment syndrome.
Yes. So it's important to get them on and get them on tight and make sure that you don't mess that up. Yeah. So put a tourniquet on, put it on tight. If it's a cat tourniquet, literally put the strap through the buckle, put it around the appendage, high and tight, couple inches above, whatever it happens to be. And then you're going to torque that strap, that hook and loop strap down, and you're going to get it super tight. You're going to strap it down, and then make sure that it's adhered. And then that's when you start turning the windlass. You turn it until the bleeding stops. You can't turn it anymore, whatever it happens to be. And then put that strap down, lock the windlass in place, and you should be good to go. And you can move on to whatever the next phase of care or the next thing from March is, right?
Absolutely.
All right. I think that's tourniquets. Let's see. Let me look at my notes real quick.
And yeah. I love tourniquets, so we will definitely be talking about more tourniquets in like just really talking about it more. Like I love them. Like I get all excited.
Oh, I know, 100%. I absolutely love them. So I think that's just about it as far as this episode goes for tourniquets. Now, let's say we've moved out of direct threat. We've gained the advantage over the threat, and we've done the hemorrhage control for life threatening bleeding by putting on a tourniquet if we need to. Let's say that we've moved into the next phase of care and we have time to do more stuff. Let's talk about wound packing, because massive hemorrhage, obviously tourniquet's not always 100% the answer. You already mentioned that for like the neck, the groin, the axilla or armpit, any of those junctional areas, we're going to use wound packing. And what does that mean?
So that means we are putting gauze down into the source of the bleeding. You know, if you took a basic first aid class, like, all right, we're going to put some bandaging on top of the wound. We're going to hold pressure and we'll hope for the best. And we've found that that's not the right thing to do. You know, even when I was in school, that's what they were taught. Like, we'll put this bandage right on top of this nasty cut and hope for the best. We'll get the clots in there and we'll be fine. But what we found is that we actually need to get gauze down into the wound and down into the source to control that bleeding. And this takes some technique, this takes some training, but you got to get it down in there to where that massive bleeding, that artery is, where it's a brachial artery up in the top, where it's a jugular carotid artery, or it's a femoral artery. Like there's this major blood coming out of the wound, and that we need to get gauze down in there. And this, can I say gauze, but it could be a t-shirt, it could be a towel, it could be something. I wouldn't use like a shop rag. I'd use something clean, but you can use regular cotton gauze. You know, if you've got the budget for it and you're can, then a hemostatic agent such as combat gauze or Celox would be a great option there as well. But you know, that may not be in our budget. Maybe we're just using some Estrol gauze or some compressed gauze, H&H gauze, something like that for wound packing.
Yeah. So, I mean, when you talk about gauze, like your top tier stuff is your hemorrhagic, hemostatic gauze, which
bleeding gauze. What is that?
Yeah, that's the opposite of what we want. And that's the stuff that has the hemostatic agents built into it. There's several of them. They're like 40 to $50 a package pretty much for that. And that's just infused with something that helps induce clotting. It's usually got something through it so they can see it in x-rays. What about like a quick clot sponge or something? Is that kind of a good thing to start wound packing with?
I honestly, like, I don't like the sponges, especially because we get, you know, in these wounds, even like a knife cut or a laceration, getting that sponge down into the wound can be difficult because you've got a bulky sponge and you're trying to get it down in there. It can be difficult. Where I do think the sponges come in handy is like a head laceration.
Mm-hmm.
You've got somebody who's got a nice head lac. Yeah, the sponge works great on there. And you know, people will buy it because it's a budget item, and I get it. You know, you can $15-$25, you can buy a sponge at Academy or sports store you're talking about, and they're just trying to save money on a budget, and I get it. But you know, there's better choices out there. Even the powders, like the powders, I don't really like either. Trying to get those down into the source can be a problem. And you know, that's another myth talking about hemostatic agents is that it causes burns. You know, that was when the first roll of combat gauze came out. It basically like burned the artery, like, and it would cause third-degree burns. So then now your soldiers were dying 3 weeks later because of infection.
Mm-hmm.
So now the new stuff doesn't burn. So like for me, like for my shop at medicalgearoutfitters.com, like the EMS rolled gauze, it's a third less the combat gauze. And it's about, I don't know the price right offhand, it's like $20-ish, give or take a little bit. So it's more of like that budget item, but you're still getting a hemostatic agent that you can use to inside your kit.
Yeah. And then, I mean, you can carry one thing of combat gauze, and then you can move into the other kind of gauzes. Like for me, Kerlix, that's something I always carry a bunch of just because it works for that. You know, if you don't have hemostatic gauze, if you can't afford it, then Kerlix will work in a pinch, right? Like it's going to flow in there. There's tons of surface area for the blood to flow into, dry up, and create clots. It definitely works. You can vacuum seal it. They've got the vacuum sealed stuff, so it's got a pretty small signature for ankle kits and other things. So top tier is that hemostatic gauze, and then next is kind of all the different Kerlix and rolled gauzes of different types. And let's see. Yeah, regular gauze, it does work. Like you can use it in a pinch. You can put it on top of the hemostatic gauze. I think that's always important to remember. You start by filling the wound channel with the hemostatic stuff, and then you can move into the other stuff if you need more.
Exactly. You can get the hemostatic agent down to the source and just use the regular gauze as a backfill. That's absolutely, it's a great choice. Just remember that if you're using the Curlex or compressed gauze, whatever you're using, you're going to have to hold pressure longer. Typically, I teach my students 10 minutes. That's a while that you're going to have to hold pressure. If you're using hemostatic agent, you're looking for 3 minutes that you're going to have to hold pressure. So it does help, even though technique is a big deal. But the hemostatic agent definitely makes a big difference in the ability to control bleeding.
Yep. So the process here, whether you're using the hemostatic gauze or whether you're using just rolled gauze or some other kind of Curlix style gauze, um, on tourniquets, we put them on over close, which I guess reminds me one thing. If you're putting it on high and tight on someone's leg, make sure that there's not a phone or keys into their pocket that's going to work against you or cause, secondary bleeding underneath of it once you drive their keys directly through their thigh.
That's going to feel nice.
Yeah. So we put tourniquets on over close. But for wound packing, obviously, the first step in wound packing is we have to expose it. And whether that means like just cutting around it, ripping around it, we have to actually be able to see it. So we expose it, then we identify the source, and whether we can do that visually or whether we have to, put a gloved finger down in there to figure out exactly where that source of that bleed is coming from. That's what we do. We expose it, identify the source, and then we pack just, get a little ball started and then pack that directly to the source of the bleeding. And we pack towards the heart because that's the source and to the bone. We're trying to fill that entire cavity with material so that we can keep that pressure on. If we just put a little ball on it, the blood pressure is just going to push it right away. So we have to fill the entire cavity with it. We're not trying to cover it up. We're trying to actually just fill it and create a ball of material in there. And like you said, if we have to backfill with additional gauze, whatever, if you have to use 2 rolls, 3 rolls, whatever it is, depending on the wound channel, that's what you're going to do until it's 100%. Then that direct pressure for hemostatic about 3 minutes and just regular gauze up to 10 minutes after that. And then what do we do?
You said it when we talk about direct pressure, you got to put your body weight into it. This is not just you're patting them saying everything's going to be okay. Like this is you putting all of your body weight into it to hold that pressure. After 3 minutes, 10 minutes, whatever gauze are you looking at, we're going to evaluate it and look at the wound. If it has no more bleedings coming out of it, then you're good to go. You're squared away. The problem comes in now, like you said, you fill that entire wound channel, and now a few minutes later, you're like, it's still bleeding. You've already put as much gauze down in there. So what we have to do is we have to pull the gauze back out because you did not get it down to the source. And you got to start over, and your patient's really not going to like you very much. But then you start over again. If you have a fresh pack of combat gauze or a fresh pack of Curlex, we would use that. But if you don't, ultimately you just reuse the same stuff. Once you get the bleeding controlled and no more blood is coming out of the hole or the laceration, then we're going to put a pressure bandage on it to kind of hold the gauze in place.
Yeah, 100%. A caveat about removing gauze if you need to, like be very cautious there. You don't want to dislodge clots that have already existed. You kind of got to get it right the first time. That's why you identify the source of the bleed. And when you've got it, that's when you start building up there. You don't want to have to take it out. And if you do, you need to be cautious with it.
Exactly.
All right. And then, compression. So we've got all kinds of different compression bandages. And we did cover a little bit of them in the previous one, but we've got just the classic ACE bandage as a compression bandage. You could use the SWAT T tourniquet as a compression bandage. It's that rubber. You can use Israeli style, the wound stop. There's like all kinds of compression bandages. What are some of the pros and cons of each of those styles?
So for me, I like the Israeli. It's nice and compact. I usually take the Israeli out of the first package. There's actually 2 packages with the Israeli, and they do that for keeping it sterile. But for me and my kits, I will take that first opening package out, and I will put it's still vacuum sealed inside of another clear plastic bag. So I will put that in my kits. The Elias is a great bandage. It's a little more bulky, but it comes with some gauze that you could use for wound packing.
Yeah.
So I like that. Like that's a plus.
I love that one.
But it's a little bit bulky, especially the 6-inch. Like trying to put that into an IFACT is a little bit tricky. You can do it, but it's a little tricky. But I love that bandage. The H&H, I love the way that is packaged. Is the H bandage. It is super thin. So if you're just looking for a bandage to put in like your day pack, or you're looking for a bandage to put in your briefcase for work, the H bandage does not take up hardly any room at all, and super low profile. So I like that. But like I said, even an ACE bandage, some Coband, some horse tack, whatever you want to call it, That could work, the SWAT T, but you just don't want that gauze moving around, that you've worked your butt off for the last few minutes to get this bleeding, and you don't want this to get moved around.
Yeah, we're also not trying to create a tourniquet with any of it either. So it's got to be nice and stable and keep that gauze, that ball of gauze, nice and still. But also, again, we're not trying to like cut off all circulation
It,
to other blood vessels and things like that.
Exactly. I know we're going to talk about in future videos about checking pulses, like where to check pulses, stuff like that. And so, with a tourniquet, if we put a tourniquet on the arm, they're not going to have if you put it on good, you're not going to have a pulse past that.
Right.
At the wrist, you're not going to have a pulse, or the ankle, you're not going to have a pulse. For the pressure bandage, that's one of the things I do check after I put a pressure bandage on. I'm like, all right, can you wiggle your fingers for me? Do you feel me touching you? And do I still have a good radial pulse or good pulse down at the ankle? To make sure that I have not created a tourniquet, because now you're talking about a 6-inch pressure bandage or a 4-inch pressure bandage. It is very easy to make a tourniquet out of these bandages. If you're wrapping it tight enough, you can make a tourniquet out of it.
Yeah, 100%. So, and really, I mean, they're pretty simple, right? Like for ace bandages, I always throw those clips away. They're useless. Just tuck the end and get it in there. Just make sure you tuck it well so that it stays. Israeli and the Oleus, they've all got their own kind of mechanisms. Is it the Oleus that's the bandage with breaks? It's got Velcro strips every so often.
Yep.
And it's all pretty simple. Like most of us have put an ace bandage on, but if not, we can usually just generally figure it out. Just not too tight and keep that ball of material exactly where it needs to be, so that you can extract and move them to wherever you need to be without a rebleed.
Yep. Just if you're doing the neck area, I usually start on the injured side and I'll go across the chest up under their armpit, get them to raise their arm up, or you move their arm up, go up under the armpit. So when they move it down, it actually applies a little more pressure there to you. Just be careful, don't wrap it around their chest, kind of hurt with breathing, stuff like that. And the hip is a problem because your person's laying on their back and you're trying to wrap it around their pelvis and all this stuff. So it gets kind of fun and kind of awkward at the same time. So just make sure you introduce yourself. Hopefully you did that before you stick your finger in their pelvis, but at least get their name first before you start doing all this.
Yes, there's a really good video. It's of a bicycle rider who gets a femoral artery disruption from his handlebars when he has a pretty innocuous looking wreck.
Yeah,
and they put so much pressure on his groin area, and I mean he lives because of it. And they don't even have wound packing. So just we're trying to create that pressure. Pressure is the key here. Pressure stops that bleed. And the wound packing is something that we use to complement all the direct pressure that we're actually putting on and help those clots generate.
Yes, sir.
All right. So we talked about direct threat. We talked about direct threat / care under fire, I should say. We talked about gaining the advantage over the threat. We talked about considering hemorrhage control. And now we've actually talked about that massive bleed control with both tourniquets and wound packing. And I think, unless there's anything else there, I think we wrapped that up for this episode.
I think so.
All right, so we've got one more section. We're just real quick. We do want to talk about a product, and there's a reason we're going to talk about this product. And why don't you take it away? Tell us what it is, and tell us kind of why we're talking about it.
So we kind of every episode we pick a product of the week that we talk about, and we've kind of been on tourniquets. We've talked about the soft T, we've talked about the cat, and like we mentioned this video, the SWAT T tourniquet. I think this one is a tourniquet that we can consider. There again, it has its negatives. I think for one-handed application, it really struggles here. There's some techniques you can do, but I think that kind of goes into some fine motor skills, which I don't know that everyone's going to have. So one-handed application is probably, it's not the best tourniquet on the market. I'll just go ahead and say that. But it makes a great pressure bandage. And if you're using it to make a pressure bandage on an arm or a leg, you can do it. If you've got both hands free, it can work there as well, but it works really good for those kids who have arms or legs less than 5 inches in diameter, where the cat and soft T can't function that well. Then the SWAT T works great for that. Also, if you have a dog, because their legs are shaped kind of like a triangle, and it's kind of hard to get a traditional tourniquet wrapped around their arm or their leg, then a SWAT T works great for that. And this is basically, it's a 3-inch rubber band that's nice and long, and it has pictures on it that says, if you've stretched out this far, then you are making a tourniquet. You turn a triangle. I can't remember the pictures right offhand, but it's a diamond, right? It's triangles and diamonds. You turn those, you've got it wide enough, you have a tourniquet created. So it's low profile. It's about the size of your wallet when it's staged up into the package. So, and it's probably around $15-ish, somewhere around there. So it's not going to kill your budget to kind of throw a couple of those in that you could use for multiple purposes. It could be used for a tourniquet, or it could be used for a pressure bandage. So I think it's a good option for people to look at.
Yeah, I agree. And they're actually $12.99 at Medical Gear Outfitters, where I just ordered a couple.
Awesome. I like it.
Yeah, exactly. Every episode, I'm making you more and more money. It's crazy.
This is awesome. I love it.
So that's kind of the SWAT team. Now, excuse me, there is a lot of drama swirling around the internet right now.
Man, like we were talking about that, like it just like it exploded overnight.
Yeah, and there's still a lot of information coming out. So maybe it's not fair if we talk about it right now. Maybe we'll talk about it next week when there's more detail and we're not jumping to conclusions. But I just want to say that it's regarding the rapid application tourniquet, the RATS tourniquet, and just like tons and tons and tons of drama and some accusations of really, really shady business practices by the people who make that, right?
Yeah, I mean, and it's obviously no secret that I've sold the RATS in the past. I think we're gonna discontinue those, and we're gonna move on, and we're not gonna sell the RATS anymore. But my stance has been the RATS is probably my least favorite tourniquet, but I think it's better than you trying to do an improvised tourniquet, whether you're using a belt, shoelaces, or 550 cord or wire or whatever. There's guys that are sold on the RATS, and that's why I've sold in the past. But just due to the amount of controversy going around it, I think we're going to discontinue it at Medical Gear Outfitters. I'm not a controversial guy. Like I try to be nice to everybody. Like I just try to be friends with everybody and try to play the nice guy. But I think there's too much controversy going around. I think we're going to back away from it right now.
Yeah, and it's not even the first time that they've been accused of and caught doing some shady business practices. There was a whole US TCCC that was kind of being used to imply that it was approved or at least recommended by the Committee for TCCC, but that turned out to be a shell corporation and not true at all. It said like recommended by US TCCC. So kind of just shady marketing, shady business practices. We're actually going to pull the RATS out of we like shooting medical kits that we sell through Medical Gear Outfitters and replace them with the SWAT T as well. And I'm with you. Like, I think that they have a place. I think that as long as you understand their limitations and the repercussions of carrying them, that they sometimes make a good backup. But I think I'm going to pull them out of everything that I do as well. And I think there's just too much controversy and ridiculousness. And since it's not the first time, I think that's the choice that I'm going to make.
I agree.
All right. Well, if you guys would like to find out more, you can go to medicalgearoutfitters.com and you can use coupon code Civilian Medical, and that gets you 10% off all day, every day. That's the one, right?
Yes, sir.
Just had to double check. Yes, that is it. Civilian Medical, all one word, saves you 10%. I just used it and saved 10% as well. So any other wrap ups before we go? What are we going to talk about next week? I think we'll talk about indirect threat or tactical field care and airway, right?
Yeah, I think so. I think this is going to be a good one. Kind of moving out of a different phase of care, and then we're going to talk about airway, about stuff that we can use to control people's airways, and some simple techniques, all the way up to maybe some a little more advanced techniques. But it's going to be a good episode.
Yep, 100%. And just remind everybody, what does March stand for? That algorithm.
So we've got massive bleeding, we've got airway, respiratory, circulation, and heat loss with head injuries.
Perfect. Well, that'll do for us, and we'll talk to all of you next week. And don't forget to check out our Facebook page. You can go to civmedical.com, and that'll take you to our page on the Firearms Radio Network, of which this show is a part. And hope you're liking it. Let us know. You can send us some feedback on both those places. So we'd love to hear from you. And Dietrich, I'll talk to you next week.
Yes, sir.
Find us and subscribe at civmedical.com.